bearing, but you're not seeing them in non-weight bearing, you already at that point know that there's been an issue in the lumbar spine and that you have to go in and investigate that if you haven't already. Then at that point you already know correcting those things should correct the torsion. The problem becomes the chronicity of those torsions can sometimes set up those motor imbalances that will be perpetual even after you've corrected the lumbar lesion. So you'll have to use these muscle energy techniques here in order to start teaching the body its more normal pattern, which the body will tend to recognize its normal pattern as long as you can keep it in front of its face. It doesn't want to do the compensation, it's doing it because it has to stay erect, just continue to walk and that sort of thing.
So when it's there, even if it's motor strategy, we've lost load bearing and load transfer. So we still have inefficiency. So then we get overactivation of certain muscle groups, depending on which side that is, that are chronic in the gait cycle. And so you can't leave things in the wrong position because we lose that watch spring mechanism. Okay, so that big efficiency of gait. So
yeah. And you can see it when you think about looking at the backside of the sacrum with the different ligaments and how they cross. If you have, say, a forward torsion where that left sacral base has gone forward, it's going to tension that sacrotuberous ligament on the opposite side. So you get somebody coming in saying that they've had this hamstring strain for Lord knows how long. They don't mention their back problem that they had years ago because they don't think it's relevant, but you see that there. But then you also have a slackening of that long dorsal ligament, so you've suddenly lost the ability to transfer that load up and across that posterior sling. So they have that inability to really produce any kind of weight-bearing stability when you're checking with that Portland test. They'll fall apart. But those things will actually end up being on opposite sides. Okay, should we talk through those real quick?
yes, talk through it one more time in terms of which one is the instability and which one is the disc, since I
Okay,
was
so
helping you not.
yeah, so the way I figure it is based on the lesion that would have instigated these problems. If we have, let's say, the instability first, instability sending that feedback loop through the psoas, right, and creating that hypertonic psoas. What it's going to end up doing is taking that sacral base and it's going to try and draw that forward. You're going to have an inhibition of the opposite hip external rotators, correct? So we're going to go through the piriformis, the short glute max, and those groups there. They're going to become inhibited and we're going to suddenly have that deviation forward. So it'll create that forward torsion, okay, with that instability. Does that make sense? With the posterolateral disc, what happens is typically, and this can be somewhat variable from time to time, but if you have a posterolateral disc, it will inhibit that psoas on that same side because you're going to tend to deviate away from it, right? You're basically dealing with either an end plate fracture or some kind of thing that they don't want to put weight on, so the psoas becomes inhibited to allow them to deviate away. As that happens, you get that sacral base just basically floating back as you get that, basically the imbalance between the hip flexor on one side and the hip rotators on the other. This becomes weaker. This one then relatively is much stronger, and it's allowed to create that torsion going the other direction.
And so in the other thing in the posterior lateral disc, think of laminectomies. So post-laminectomy, you sometimes are left with that sacral lesion. Okay, so the motor strategy, and actually I think it's fairly reinforced because of the surgery and the chronicity. And so that might be why they're coming in with pain, or we can't, and remember we need to have the lordotic spine and the hip extension anterior rotation for efficiency of gait. So we need to get that moment going. So we can't, again, part of what you're quickly looking at, and I think I agree with Eric that this doesn't take that long to retrain, because I do believe there is the efficient motor strategy, and so once you can key into that and say this is how we want you, then the inhibition or facilitation improves. Okay, so let's practice that last one if you can remember it.